Good afternoon. I see many familiar faces here. For those that are new to me, I'm Jonathan Sherville. I'm the Director of MERIT, which is McMaster Education Research, Innovation and Theory. It's a long title center. And we're quite delighted that you're joining us here for the inaugural Norman Lecture in Education Research. Before we begin, I've been challenged with some conversations I've been having within our center to be thoughtful and reflective of the traditional territories of the Anishinaabe and the Haudenosaunee, governed by the Treaty of the Dishwith-Wansaloon Wampum Agreement. But that we don't want to be perfunctory when we talk about that. And so I hope that our beginning here can help us reflect and center on that we're going to hear a conversation about education research. It's a conversation for an hour. What does it mean beyond that? Do we just simply have a land acknowledgement and we're done? Where does the responsibility lie with us? How do we think about our own research? How do we think about the research traditions and things that we say are inside or outside? What's the responsibility of the institution? And maybe as we hear our conversation today, it infuses within us a desire to kind of challenge an assumption that we have about this is the way we do things because we've always done it this way. This is the right way to do it. Maybe we should think about what are the other processes beyond this hour together that we should think about considering or advocating for or challenging. And what's our responsibility as individuals here who are meeting on these traditional territories? I don't have the answers for that. But I know that you, like me, are probably going to want to engage with that idea and be thoughtful about that idea. And understand what is my own responsibility and where do I sit within this larger center, within this larger faculty, within this larger institution, and what happens on the other side of our conversation today. And I think that is the framing I want to take, and perhaps I encourage all of us to take as we think about that. MERIT is an education research center, but we want to have you part of our community if you haven't heard about us yet. You can find a little bit more at merit.mcmaster.ca. We have events throughout the month and throughout the year. If you are interested in education scholarship, if you're a big education nerd like me, like many of the people that you're going to encounter here, hopefully this is a home for you to ask those hard questions, some of them we started with. Maybe it's a place to find some near-peer support. Maybe it's a place to find some insight and opportunity to take your innovation or your question and move to the next step. And so we're really excited, and I'm going to ask Jeff, as he's been inviting me to call him because he gets very uncomfortable when I call him Professor Norman, which I might do to make him feel uncomfortable, to come and introduce the inaugural lectureship, the Norman Lecture in Education Research. Without further ado, we'll go with Jeff.
Thanks, everyone. This is a very important month for me. The first is that this is the first inaugural Norman Lecture, and in a few minutes I'll reveal how this thing came about. The second is, this is my diamond jubilee. This month I have 60 years at McMaster, believe it or not. Oh my God. Hard to believe. Those two events are related. I'll tell you a little bit about my early career, such as it was. I came here in '65 to do graduate work in physics. I was going to be a nuclear physicist. I figured that the Nobel Prize was looming on the horizon. But it didn't take long to realize that I didn't have much of hope as a physicist. I was pretty bad. And if there was any doubt, the file of rejection letters that grew to several centimeters thick left no doubt whatsoever. So I was looking around for jobs, and to make a long story short, through a series of random walks, I ended up in medical education back here at McMaster. And here I've been for the next 55 years or so. And at the stage I'm at now, over the last few years, I spend more time looking back than I do looking forward. And as I look back on the 50 or 60 years that I've been at this game, I realize that I was part of a very blessed generation, that a few things fell into place that made my life just absolutely wonderful and couldn't have been any better. The first was that we were born at the right time. We were born at the time when jet aviation technology came into play, and so it was feasible for people to fly across continents and fly across oceans to other places and communicate that way. And so that was the first important thing. The second thing was medical education, health sciences education was very much at the beginning. And goodness knows why I was selected as the first employee of what now ultimately became Merit, but I assure you, I had absolutely no skills whatsoever. I didn't know statistics. I had never even taken high school biology. But the good news was that everybody else in the field was about as dumb as I was. So we all learned together. And basically, the first generation of these folks all learned on the job. And we grew. And we started as a small community, but we kept as a larger and larger community, but always communicating. And as a consequence of being perhaps on the ground floor and being fairly industrious, I had a wonderful time, both at home and teaching and doing research, and also I was able, on the basis of somebody else's dollars, to see an awful lot of the world. I had many, many trips, and it was a wonderful experience as a tourist, but it was also a wonderful experience as a faculty member communicating with other faculty members. And back in those days, it was routine for people to go to 2 or 3 or 4 conferences a year, to be invited to several places in a year. There was all sorts of communication between institutions, which made us a larger community that initially numbered tens and then hundreds and perhaps then thousands. And then along came COVID. And suddenly all that stopped for 2 years entirely, but it never got replaced, because what happened was that we discovered Zoom, and we discovered that rather than pay $2,000 for somebody to come from some other institution, we could pay a couple $100 for an hour of Zoom call. And I don't think we've counted the incalculable loss to the research community as a consequence of that thing that happened. What I see even locally is that many of the people here in our own shops don't get the opportunity to communicate or work with other people as much as they did before. It doesn't help, of course, that we're now used to 2 or 3 days a week at work. So, but in thinking about it, I was part of a community that was international and that was incredibly vibrant, and that we all learned together. And I felt that when I looked around, that was very difficult, that wasn't happening anymore. The other thing that made my life very good is that at the end of the day, I got quite a lot of money. And so I decided one of the things I can do with that money is essentially to try and recreate the kind of inter-institutional space that we had before. And therein was the birth of the Norman Lectureship. It's one thing to have Rola on a Zoom call for an hour giving an interesting talk. It's quite another thing to have Rola here for 2 or 3 days, communicate with us individually, and working with us. And so the lectureship is kind of a small replacement for the kind of community that frankly used to be, but I fear may not come again. So I'm delighted that this is happening. I'm delighted that Rola is our first speaker, and I'm really looking forward to the lecture. Thank you very much.
It's my great pleasure to introduce Dr. Ajjawi, who is a professor of medical education in the Department of Surgery and a scientist and the Associate Director of Research at the Center for Health Education Scholarship, University of British Columbia. Dr. Ajjawi is also a physiotherapist by clinical background. You will recognize her work in the literature as an international expert on workplace learning, including clinical supervision, feedback, equity and assessment, and belonging. She is a Karolinska Institutet Fellow in 2021 in recognition of her contributions to health professions education research. She currently serves as the chair of the International Association for Health Professions Education as part of AMEE, and is the incoming editor-in-chief of medical education. So if you get a chance, you can beg to her why you're gonna for peer review yet again for your next submission. Dr. John.
Is that working? There we go. There we go. I don't think I ever had a problem projecting, but we'll go with that. Let me know if I'm rustling too much. Thank you so much. Thank you for being here. I'm honoured and humbled to give the inaugural Norman lecture. And if I can say, my PhD was on clinical reasoning. So I read a lot of Jeff Norman's writing and was definitely schooled in thinking around clinical reasoning, but some of my favourite writing of Jeff's were the critiques of the quality of medical education research that came through in your editorials, and in particular, the efforts you made to really lift the field and to lift the quality of scholarship in medical education. And I hope we continue that tradition. So Jeff, I look forward to your critical feedback after this talk. So I am going to be talking about the emotional work of feedback, a program of work I've been doing for a while. I'm also going to start by acknowledging the traditional owners of the lands on which I live, work and play, the Musqueam people. I am a settler in Vancouver. I moved here a year ago from Australia, so I'd also like to acknowledge the Wurundjeri people of the Kulin Nations and pay my respects to their elders, past, present, and also any in the room now. I want to start this talk with a story. I was recently invited as content expert to give feedback on a research proposal for a PhD confirmation. And I had done my homework. I read the proposal and attended via Zoom because they were in Australia. And they gave me the floor, and I started by talking about my thoughts about the research proposal. And as I kind of continued, I could see the supervisor's shoulders rising. I could start to hear some huffing and puffing. I saw the student become quite, she looked a bit sad, she looked a bit disappointed. I was being quite critical with my feedback because I was thinking this is the opportunity to really support developing the quality of this research during the confirmation, as opposed to when the research has been done in the defense at the end. But what happened was that the other people in the room started to get really flustered. And then they started saying, but your research is really good, these are only minor recommendations. And slowly, as emotions intensified, I could feel myself just stepping back and agreeing and just saying, actually, no, it's great, but you just might want to pay attention to these things. And afterwards, I felt that I'd let myself down, and I felt that I'd let the student down. And I'm going to try and unpack this through the talk. And those emotions really stuck with me for a while, and I still actually feel them as I tell the story about not being able to have a conversation about the work. So this talk is structured in 3 parts. I'm going to start by really giving you an outline of the landscape, really briefly how the literature has talked about feedback and emotions. Then I'm going to kind of layer in some complexity around what emotions are and what role they play in learning and in particularly in feedback. And then finally, I'm going to leave you hopefully with some strategies towards working productively with emotions in feedback conversations. And ways of leaning into emotions, and what you were saying, Jonathan, about perhaps leaving here to reflect afterwards and do things differently. Perhaps that might be an outcome. So, feedback and emotions. We've traditionally thought about feedback, We've traditionally thought about feedback as information that we give to a learner to help about their performance in relation to a standard. And that information is generally unilateral from the expert, the teacher, and it lands, we don't really know whether anything changes or not, and we hope for the best. The research on feedback and emotions has typically conceptualized emotions as discrete passive reactions to feedback information. So what do I mean by this? If you get positive comments like praise, you might have some happy feelings or some relief. If you get negative comments that are critical about your work and performance, you might feel anxious, sad, or angry. And these are passive reactions to the information. Others have said actually emotions have a more active role in terms of learning and memory processing, and they're not merely reactions, they actually pre-shape action. And so, for example, this work by Kevin Eager and colleagues talk about how fear of looking stupid, for example, might actually lead us to perhaps not ask questions, to perhaps not say what we're not good at, to perhaps even deflect the feedback, or no, that's your opinion, or avoid feedback altogether, and or avoid the supervisor as well. Sometimes harder to do than other times. And finally, there's also work that suggests that feedback can have some long-term damaging emotional legacy. Who here can remember an experience where you've had feedback and it still rankles somehow? Like you still feel like you were treated unfairly, or maybe that, you know, that wasn't true of you. I certainly still have that from my university experience. And it's associated with assessment feedback. So, but of course, feedback isn't just information. We've spent a long time studying what are other factors that mediate the influence or effects of feedback. This is work conducted by master student Samtilio at UBC. And she found that there is this thing called an educational alliance, and it's the perception of the learner or the trainee of the strength of the educational alliance can mitigate or mediate the effects of feedback information. What do I mean by that? That's a lot of jargon. Let me try and unpack that. There's three components to an educational alliance. There's a bond, which is kind of like the relationship. And if we have a good relationship with our learner and there's trust and we show that we care about them, then their credibility judgments of us might be positive, and then they might consider that actually what we're saying is something that they should pay attention to. If there's shared goals and activities, again that sense of care can strengthen the perceptions of an educational alliance. Let me give you an example, and I'm going to try and give lots of examples in this talk, especially when I get a bit jargon heavy. This is an example from one of the papers, and this is a participant who said of his supervisor, when he described a feedback experience, she opened with, "You did it all wrong." But he had a positive emotional response as a result of a strong alliance with his supervisor, who he described as wanting the best for him and really caring. Now, the one thing not to leave this room with is that that lady said that I can start with, "You did it all wrong." That is not a message. But the message is that within a context of an educational alliance, then the information, the message, isn't the only thing that determines the emotional response that a learner has. However, over time, I think we can all agree that relationships matter. There's been a lot written about that now in medical education, especially in respect to supervision and feedback. There has been some unintended consequences. In my many feedback workshops that I run with faculty, I've had chats with people who tell me, I have coffee with my trainee once a week. And I'm like, and that's the bond piece, but that's not the feedback. So we ended up writing this paper, Glenn and I, to say the relationship is the context within which we can leverage feedback conversations and really talk about how we can improve practice. The other thing I've been noticing in talking to people is there's a real fear on the supervisor's parts of upsetting the learner and damaging the educational alliance. And more recently in my travels, supervisors are telling me they're afraid to give feedback for a multitude of reasons. And so we're establishing a situation where there's feedback avoidance, potentially from the learner, but more importantly from the supervisor. And notice I haven't given a lot of research on the supervisor. That's because there's a bit of a gap. A lot of the research has looked at the learner's reactions and emotions and not the supervisor's. Give or take a few studies, like Dennis in 2018. And I think part of this problem of feedback avoidance is that we don't have very good strategies in medical education to work with emotions. Who's heard of the feedback sandwich? That's what I ended up doing in that feedback confirmation, and what my colleagues in the room were trying to do. They felt like they needed to sandwich my critical comments in between pieces of white fluffy bread to make it palatable to the learner. But what it does, and I think what I left thinking, what message did this learner take away from this? This is so muddled. So I feel like we need better strategies for working with emotions if we are going to do this well. So let's move into what are emotions, okay? And here it's going to get a little bit more kind of theoretical, but I do have examples. It will not surprise you at all to know that there is no consensus or unifying definition or theoretical framework on emotions. It depends what lens you bring to it. This is just one from social psych that I quite like, and that's because it shows the dynamic interplay between cognitive, social, physiologic factors that shape individual experience, that are shaped by individual experiences, cultural concepts, and social contexts. I think one of the reasons I quite like this is because in their work they really show how the physiological factors alone don't really correlate with the lived experience and the appraisals we make about emotions. So we need to look at the two hand in hand. The other thing that they also talk about, some of you might have heard the distinction that emotions are the physiological piece and feelings are the cognitive, meaning-making, interpretation, appraisal, whatever word you want to use, that we make of emotions. That is not an accepted consensus. So if you didn't know that, don't worry about it. If you did know that, I'm going to use them interchangeably in this talk, okay? So emotions, for brevity, are embodied. You know that feeling when maybe you're kind of sensing maybe this is not a safe area to be walking in. Your body might react first, the hairs on your arms might rise, the back of your neck tingle, your heart rate might come up before you even register that, wait a minute, something is going on here. Maybe I need to do something different. And so that, it's relational, it's in response to something, but it also shapes your action, because I might then go, maybe I need to go walk somewhere else. And it shapes other people's actions around you, because if I'm walking with someone, they might go, are you okay? Do you need something? Or can I help, or something like that. So they do a lot more work than we give them credit for. The other thing I just want to raise is this idea of positive and negative. And I'm going to come back to this because I think this is really important in the feedback conversation, is that we attribute valence, it's the technical term for positive and negative, to the emotion itself. So if I say stress, for example, what do you think? Negative. I want to challenge that, and there's been a lot of critique of valence as anchoring to the emotion itself, because who determines whether it's positive or negative, for whom or for what? And so the valence of emotions are affected by how individuals view the social context in which emotions are experienced. And over time, this valence might change. The simple reason I'm bringing this up is the whole avoidance of negative emotions is a label we're attributing to something that might not be experienced in that way. And also, negative emotions aren't always bad. Some of you might be really familiar with this theoretical framework. This comes from psychology. This is probably the most used one in medical education and also assessment research because it looks at achievement emotions. I don't want to dwell on this. If you're interested, Pekrin has written tons. All I want to say is, notice how even here, positive emotions can be both activating and deactivating. If you get feedback that you've done well, you passed the standard, maybe you don't want to continue trying. That was good enough. Tick. You've made a judgment about how much control you have and the value of that, and that influences your appraisal of the situation. Similarly, negative, so-called negative emotions can also be activating or deactivating. Let me give you one more example, and yeah, Pekrin's amended the table to add in the retrospective how emotions can change over time as you reflect back on situations. Let me give you one more example here because I think this highlights in a more situated way what I'm talking about. This is work from Jimmy Beck from his PhD, UCSF. This is a trainee saying it was my first week of intern year and we had a pretty sick kid. I just remember feeling this fundamental discomfort and almost fear. And my attending was like the ball's in your court. It was a scary time because I was given agency over a patient for the first time, but it laid a good foundation in terms of trusting my own judgment. That would have not been as powerful if I didn't feel that fundamental fear of seeing a child get sick before my eyes. So stress can be super activating. It doesn't have to be something we avoid. But also what you notice here is we can have multiple emotions. We can have discomfort, fear, and also trust circulating, which in this instance supports the student to actually, or the trainee, sorry, to make sense of the experience. And then looking back, of course, too. The point here is that stress is a catalyst for learning, and we can't avoid emotions in the work that we do in health professions education. So just a little bit more complexity before we move on to the next piece. I've already said there's multiple ways of thinking about emotions. I'm not saying some are bad and some are good. I'm just saying there's different ways. And those ways determine what we end up doing in practice, what we do around feedback. So really quickly, physiological, located inside the body. The psychological says emotion is a skill, we can train it, we can manage it, we can suppress it, we can work with it. The sociocultural recognizes emotions as having social, political, cultural effects. I will give examples. And the final discourse, drawing on emotions, reflexively thinking about emotions to act intentionally. Why do I bring these up? Firstly, I'm interested in sociological kind of work, and when we think about sociological work in emotions, we think about what is the work that emotions are doing. That's the question we're asking. And so we mapped it out. We mapped it out in the feedback literature in medical education. So it probably wouldn't surprise you that the majority of literature around feedback in medical education treats emotions as purely physiological. But the question is, well, what does that mean? What does that do? Well, what that does is that we say to people, well, just wait till the emotions go away. They're a distraction. Just ignore those. We pretend that they're not there. And we'll either delay the feedback or we'll do it now and you just have to work with it. The psychological, I thought there'd be more of this. I think there was a thing about the way the coding, and it wouldn't surprise you to know that many people didn't even define emotions, so there was a bit of interpretive work here. But let me give you an example of this. So emotions are something to be managed by the individual in order to learn from feedback. I mean, that sounds good, right? But there were things like, there were interventions to teach medical students resilience with the idea that that will help them manage their emotions. So instantly there'd be learning that need to be managed. The sociocultural surprised me a little bit, and I have to say I think this is because of Chris Watling's seminal work where he compared medicine, education and music. And really he brought into our consciousness the idea of feedback cultures and how feedback cultures really influence what we do. And so the idea that trust matters, and where there's trust circulating in the environment, we might be more willing to have feedback conversations, same with care. And then finally, reflexive practice. We saw less of this in the data. My point here isn't to demonize any one particular discourse. It's merely to say that we have relied on one too heavily, and maybe we need to think differently about it. And that resonates again with more recent research by Javid Sekera, where he compared the ways in which we work with emotions between medicine and nursing. With medicine and nursing, they were one bundle, against teacher education. And what he found was that there were distinct ways in which we talked about education. In medicine and nursing, we wanted to make emotions more accessible by making them explicit and focus on skill building. Again, not a bad aim, but there was a bit of shutting down whenever emotions came up. Whereas in teaching, there was a lot more likelihood that, that's probably the wrong lingo, but they were more open. At least the literature talked more about leveraging emotions and thinking about their social, the social function that they serve. And I'm going to come back to this point because I do think it's important. So let me sum up this kind of heady section of the talk. I said emotions are complex, they're multifactorial, they shape action. In 2013, McNaughton said, and they are very much disciplinary. We have feeling rules about how we can show emotions within medicine that are shaped and socialized in particular ways. In 2013, McNaughton said that emotions are the ever-present absence. They're everywhere, they circulate everywhere in the learning environment, but we treat them as if they're absent. I think that's changing. I think we're recognizing more that emotions exist, but we don't know how to work with them. And let me give you one final example of that. In a recent PhD by Mills, she looked at remediation programs across a number of institutions. And you can imagine remediation programs, learners, there's a lot of emotional load, right? So a lot of the remediation programs acknowledged the emotions and the intensity of them, but very few, very few actually explicitly utilized emotions to improve the learning process and address them in the remediation program. Okay? So what can we do about this? This is the final section. I think my message is clear here. Rather than trying to suppress emotions, we should lean into them and try and leverage them, when possible, to support learning. What does that look like? I've mentioned emotionally reflexive practice. This is when we use emotions and we are reflexive about them. We reflect on one's own and others' emotions to make decisions about how to engage with, interpret, and act on feedback information that then moves us forward. And here we recognise that unpleasant emotions, when reflected on in a supported and structured environment, can catalyse growth and productive action. Let me give you an example of what this might look like, because I think it will give a bit more flavour to this idea of interactions, power, and cultural norms. I was recently in a supervision meeting. I was a supervisor alongside Kevin, Eva, and the PhD student, we could tell, was feeling flustered. She was getting frustrated. We had been going around in what felt to me like we were going round and round in circles, trying to come up with a problem gap hook for her PhD. And anyone who's been in this situation will know it can get a bit tricky. But she was getting visibly frustrated. I was getting frustrated as a result, and I just kept throwing ideas at her. And Kevin kind of said, "Can we just have a timeout and a temperature check, please?" And she took a deep breath and she said, "I'm feeling really frustrated at the moment." And in that moment, we could have a conversation about, is it something we're doing that we could do differently to support you in this process? Also, perhaps, what is it that you could do differently, maybe that might be useful, and also to reassure her that she's only a couple of months in and it's normal to feel frustrated at this point. Glenn had a word, he called it productive wallowing, where you would wallow in the literature for 6 months, but productively, and I didn't think we were necessarily doing it productively. But since, it's made a big difference. Now, not everyone is Kevin, and some of us make mistakes. And when we make mistakes, where we perhaps rupture an educational alliance, we need to be brave enough to repair it. And this is where our future work is heading. I've got a master's student, Tiffany Berger, really excited about where this can go. The idea that what do ruptures look like in the educational alliance, and how do we work to repair them? If we borrow from other literature, these are some ways. Is acknowledging if perhaps there was bias, apologising, practicing inclusive behaviours, and a collaborative processing of the ruptures. But we don't really know what this looks like in our contexts of medical education, supervisory relationships. So we're going to look at general practice, family medicine here, and we're going to look at internal medicine, because Tiffany's an internal medicine specialist. And there's something I reckon really interesting about those contexts, because my hypothesis, at least in my mind, is that in family practice, there is a real need to repair relationships, because you're in a smaller environment, you're going to see them a lot, maybe you're with them for a long time. I wonder whether in internal medicine, the turnover is so high that you might go, I won't see you again. I don't know, my hypothesis. Watch this space. But just to give you an example of what I think an educational rupture might look like, this is a quote that comes from, again, Tilia's paper. This is classic, right? So this is about a supervisor, a student saying, he came in after the weekend and he asked me, how are you doing? And I thought he meant me. So I started to answer like, oh, it was a good weekend, I did this with the kids or something. And he's like, oh no, I didn't care about that. I'm talking about the patients. Now this supervisor might not know that this led to an educational alliance rupture, but the trainee talked about it. How do we know if the trainee doesn't tell us, because they're no longer feeling safe? And that's also one of the issues we need to tackle, and I wonder whether they might hear it through other mechanisms and in that case perhaps do something different. But I just thought I'd give you an example, because outside of medicine, this would actually break feeling rules. I'm getting a nod in the back. So one more concept I want to introduce. I've been talking about emotional reflexive practice, which is in a dyad I want to move us out a bit more and look at this thing that's called emotional climate. And I don't know if some of you have heard about emotional contagion. That's more psychological. I'm coming from a more sociological perspective here. And it's the idea that affect, emotions circulate in the environment. Like that story I started with about I could feel the heckles rising. Even though I was on Zoom and the other side of the world, I could tell the emotions were circulating. And it affects me. This is research currently under review. This is led by Rebecca Olsen in University of Queensland. She's interested in interprofessional collaborative care. They did some ethnographic fieldwork looking at interactions in oncology. And they kind of looked at who did what, who said what was the emotional climate like. And I'm going to give you just a brief example, probably not doing the research justice, but where there was very rigid, task-oriented handover like routines where they just go through patient, 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 there's no, what they saw is a complete lack of interaction from other members of the care team. Versus an emotional climate that was perhaps more light, more jokey, where people knew each other and asked questions of each other, then other healthcare professionals contributed more. Now, I'm not suggesting you do jokes because actually that can be quite challenging, and if it's not authentic to you, another oncologist, what they did is they created space to talk about a patient who had just died, or about the suffering that one of the patients perhaps was feeling. So just to give you some language around this, that emotions circulate. If we don't deal with them, they can intensify. And they stick to some bodies more than others. So stuck to me after that feedback interaction. But also what Sarah Ahmed means here is that they stick to certain bodies more than others. For example, anger is a trope for Black women. If they express assertiveness. In written feedback conversations, we talk about men and appraisals, and this is published data. We talk about men being assertive and women being delightful. Because when a woman is assertive, she's being bossy. And that's that last point there, is where being emotional comes to be seen as a characteristic of some bodies and not others. This paper is currently under review. This is some work we did ethnographically funded by the College of Surgeons and the intensivists. And just to show you the point about it sticking to some bodies more than other, we found that particularly women in our cohort were given feedback about having the wrong emotions. This is actual feedback that they got about how they were displaying the wrong feelings. That they were coming across as an angry mum, that maybe they were hormonal. This is how particular, I don't want to call them biases, because I think they're more than that. And what was curious to me was that some of these trainees just went, oh well. This is how the gendered climate of surgery continues, because they've been socialized into feeling norms that makes feedback about emotions appropriate. And one last point about gendered work is who does the gendered work of emotions. This often falls to women who are the relationship maintenance experts. Not always, but often. But relational work is hardest to do when everyone is overworked and burnt out. And that's really important to note when we ask more of our supervisors. So let me wrap up. Hopefully, I've not left you feeling like this. But I've given you some words to think about the emotional climate, how emotions circulate and stick, how they might intensify if we don't deal with them, given you some ideas around giving space for emotions to be addressed and then not escalating. So let's do a final reframe of what I've been talking about. Emotions are multifaceted, complex, and their effects depend on the social, cultural context. They are intrinsic to learning, feedback, relationships, work. They are what makes us fundamentally human. And they are discomforting. Learning should be discomforting. In that last paper I showed you, it was actually a critique of the ways in which psychological safety is being done in medicine. It's being equated to comfort. Safety is not comfort. If you're doing psychological safety well, you should be uncomfortable. There is a level of discomfort in interpersonal risk-taking. So let us be more comfortable with emotions, even the uncomfortable ones. See emotions as less disruptive and more generative, and think about feedback, especially informal feedback, as creating a space day to day to speak about, interrogate our practice, and invitations for exploration. And just to close the circle on the story I started with, I wonder what would have happened if we had a temperature check at that point. And the supervisor said, "I disagree with you. You're wrong." Or the student said, I'm really scared now. What does this mean for me? And we could have opened up a space for those emotions. And then I could have worked out what would have been best for that student at that point. And maybe it was a conversation later, maybe it was just written comments, or maybe it was a collaborative conversation about how this thesis could look differently that then they could decide what to do with afterwards. And that's it. Thank you. Questions? Yes?
I loved your comment at the end there, how uncomfortable feedback can be given in a psychologically safe environment. How do you promote that in your trainees and learners so that they can recognize that critiques and uncomfortable messaging doesn't mean attacking and psychological harm?
So, absolutely. So when I was a clinical educator, I would often say at the beginning, I'm here to help you learn. I care about your learning. These are the times, or this is how we're going to do it. We're going to meet in these times. We're going to have informal feedback conversations every day about your learning. These are just about your learning. They might be a bit uncomfortable. And you make it an expectation of the place. This is just what we do around here. We talk about learning and the practice. And we talk about what does good look like in this practice. So you're not saying you did this wrong necessarily, but you are saying, well, if you were doing this in this context, this is what good would look like. Now, you might want to think about doing X or Y, but it's not about them doing it the way you do it, but actually then kind of having a conversation about what does good look like. And if it's in the context of an educational alliance, that can also help. So I know some of you might be thinking, well, you need a lot of time to do this, and my trainees are with me for like half a day or something. Lola Farrell did some work. We did this together, and she found that if you start with a conversation about goals, hi, what's your name? You're here with us for how long? What would you like to get out of this? That instantly kind of just shifts the focus to learning, not teaching, and it shows that you care about their learning. Okay, you want to learn about that. I think this is also important. We can do both. Now, you're going to go see patients and we're going to reconvene at this point and we're going to talk about this. So these are just some ways. Sometimes it is going to be uncomfortable. I've stopped talking about psychological safety because some people will never feel safe in certain spaces. Also, it's not a destination. We can't ensure everyone feels safe all the time. So I think emotional climate for me is just kind of being reflexive about what's happening in the room, when and where, especially if you have multiple people, because someone's comfort sometimes is dependent on someone's discomfort. And managing those dynamics, especially for underrepresented students, is quite challenging. Ooh, okay.
Thank you. As you're talking there, part of what you were describing was a bit of framing what the process will be around the learning and the feedback. And I'm wondering, also listening to you, whether there's any research that's been done around framing some of the values maybe as well, or providing messaging to learners that help to support them to feel like, for example, that student who is presenting her dissertation proposal, to address before the feedback arrives that this is all about trying to make your work better at this stage, and like to sort of get at the, supporting those values around this isn't about you being bad or wrong, this is about our goal of trying to help you to be the best that you can possibly be.
And I think that part of the framing, the pre-brief is super important, because we talk about the debrief but not the pre-brief. I noticed there's been a lot of research that talk about values. There's been stuff on goals, but I do think they're absolutely fundamental to how we practice and what sort of environment, emotional climate we want to set up within the learning environment. So that kind of pre-brief is very useful. Yeah. Jonathan, Renata, and then a question on the back.
I wonder if you have a comment specifically to the sociocultural setting of medicine, where, at least in Canada and many other places, we introduce this idea of EPA, which is micro-assessment. The promise is that it enhances feedback, but the harm is that it's part of this small little assessment piece of data that then carries forward. And so now you have somebody who's trying to do that role of teacher, but simultaneously playing the role of assessor. And I can't imagine that the emotions have a neutral valence there.
Yeah, so...
Should we get rid of EPAs to make it more controversial?
I shall be more diplomatic. I think the promise of competency, or the promise of workplace assessment and in EPAs was that they were more contextual and that they were lower stakes, and they allowed for revisiting or being able to close the feedback loop, which is super important. But by virtue of anything then being documented and becoming part of a record, when a competency committee looks at this portfolio of evidence, they have to recontextualize that data and make sense of it. So anything that ends up on that record could, at a later date, be interpreted based on other happenings that happen down the line. So that automatically raises the stakes up to what happens in them. And so they become way more performative and less about learning. Do I think that you should get rid of EPAs? I certainly know that they are burdensome, and your work with ELIF found that there's a lot of negative emotions wrapped up in them. But I think maybe coming back to the previous question asker, maybe it's about the pre-brief and the context in which we do these with our learners. I have wondered sometimes whether some EPAs could purely be just for the learner. They're not documented anywhere. Now, I don't want that to happen as something else people need to do, but maybe if we took away some of the burden, reduced total number of assessment, and spent more time on the learning piece, then maybe that could be the way to do it without getting rid of them completely. I don't know. It's worth a try. All of that around certain questions. There were two questions, but I don't know what you want to do time-wise.
I think if you're comfortable with it, in the audience, maybe 2 or 3 more questions?
I'm more than happy. I think that I saw a question
John
behind
Renata
it.
actually had touched on my question, which is about the elephant in the room of the assessment piece for feedback and medical training. So.
Yeah, look, assessment always does double service, even when it's formative, and Jeff, you can intervene at any point. Even when it's purely formative or phasing out that you don't really think about, they're always for learning. There's always a judgment piece as well. They always serve multiple purposes. But I guess it's the question of what are we foregrounding and what are we backgrounding, and what educational alliance context are we working with. And those are the things I would be thinking about. There's a question here.
Yeah, thank you so much, Professor Ajjawi. We met earlier this afternoon. I shared that I work in faculty development. I'm curious of all the best practice ways that we give learners feedback. Do those all directly translate to faculty feedback, or are there nuances?
Yeah, I love that question. I was hoping someone would ask it. I cannot tell you how many feedback workshops I've run in my time, and I genuinely don't think they change practice. So much so, honestly, I want someone to show me that they change practice. So much so that I called the last feedback workshop, oh no, not another feedback workshop. No joke. I'm being flippant. I think this is feedback in particular, I do think there is a gap between the research, the theory, and the practice. We have been trying to address that. In the project I mentioned that was funded by the Surgeons and the Intensivists College in Australia, development, we brought, I don't know how much of a preamble to give you on this because it had multiple phases. One of the things we identified is that there's, even within medicine, there's specific feedback cultures. Surgery does feedback in particular ways because they're co-located around the body, and a lot of it is procedural, and they forget a heap of other things. And then the intensivists, their data is all over the place about performance-relevant information. They're often left blindsided by feedback. So all that to say is then we brought teams of trainees and supervisors who wanted to work on their feedback within surgery, within intensive care. And we did a little bit of what is feedback, what are new models of feedback, more process rather than information, and they picked something they were going to work on. They went away, and they came back a month later. We did this via Zoom. And it's like, well, did it work? And so one person was going to ask for feedback more. One person was going to change the roster so they could be with their trainee at the same time, at a point in time during the day in intensive care, because their rosters meant that they never crossed paths and were together at the same time. One person said they were going to have that difficult conversation with their trainee. And so they were accountable to us because they went, and then we did more, and we did that 3 times. And even then, changes were so idiosyncratic that we're struggling to write that up at the moment. But I think it made more of a difference than a one-off workshop. In saying all of that, I think it maybe got people to think differently about feedback. That definitely happened. They acknowledged they had more active roles. They recognized the role of emotions. But some of the systemic things weren't changed. But some did change. Some did have more of those day-to-day informal conversations. My argument is, if you do that, the day-to-day informal, nothing should come as a surprise at the end. Every day, or whenever you're with them, that informal learning conversation doesn't have to take long. Pay attention to this, maybe you want to think about that. But then it's a different thing as it starts to escalate. We end up in that is, remediation is a whole different thing. But I don't know if I've answered your question, but that's what we tried to do faculty development differently. And I think it was better, but I think it was problematic and obviously resource intensive. I don't know, that feels like a negative note to end on. One last one. Are you go on.
This might not even end up being a question, more so
Okay.
as like a connection that I made. But when you started talking about cultural norms or the socio-cultural
Yeah.
conceptualizations of emotions and how they stick to people and whatnot, I don't have a health education background. I'm hoping to apply to the master's program.
Oh, here we go, future student.
So I'm here scoping my surroundings, but
Have some more coffee.
it reminded me of this social medicine course I took, where there's a professor named Dr. Rita Jackman from Birzeit University, and she was talking about the Arab conceptualization of emotion and health as one. And so when you would talk to a patient in Arabic, you would ask, how are you feeling? They would often say, I feel unhappy, me reflecting their health. Or they would often say, like I'm wrinkled up, or something that implies an emotion, even if they're talking about the physical. So I guess I wanted to ask, when it comes to feedback, or when it comes to a health education or medical education environment, there are people who conceptualize, health and emotion or health and mental health as inseparable. And so how do you encourage this kind of discourse and awareness of emotion?
Yeah, I love that you asked that question. One of the things I took out, because it was very full, is the idea that cultures in terms of countries deal with emotions differently. I've got a colleague, Marco Cavallo de Fio, from Brazil, and he says, you people, you waste so much time on this. He's like, it's normal. I cry with my patients all the time. They are suffering. I am suffering with them. It's fine. Their expression of emotion is totally open and acceptable. It is more that within Western kind of, the historian is in the room, but the ways in which medicine has evolved is an objective, rational, distant, and I'm not saying you need to have emotional diarrhea left, right, and center, and that's not what you are suggesting either. But I wonder whether we can relax what the feeling rules are a little bit more around the practice of medicine. So to answer your question, I haven't seen a lot of research, but I do recognize that culturally, different cultures have different ways of relating to patients, and maybe that gets some IMGs into trouble, international medical graduates. So worth reflecting on. All right, is that a better note to end? Thank you.
I want to thank all of you for attending today. I think our conversation has been enriched by the perspectives you brought. Dr. Ajjawi, you've done wonderful in this inaugural lecture, taking a complex topic and continuing to give us some framing of it, but at the same time challenging us to think about where to go next. In a good academic fashion, introducing a number of questions for further pursuit. Before you go, I know Rola will be available to have further conversations and certainly continue your conversations here. There's two potential takeaways that might bring me back to our conversation moving forward. The first is a free resource. You've seen it advertised here. These are a number of resources that offer second-order review, or put another way, a synthesis that we think is practical that might help you advance your own practice in teaching. And I'm feeling nervous now that we may or may not have one with feedback, and I hope it would pass your muster. The second is, and more importantly, to bring you back to our conversation, November 18th, we're hosting a day-long conference held at the University Club, David Braley, which is on Main Street. It's looking at the idea of mixed methods research and the methodologies underscoring it. Follow Merit, and you can learn more about this. This is a free conference that will be open over the course of the day. You'll be able to be challenged about how we can think of problems using new methodologies for some of us, but well and rigorous established methodologies for others. So we welcome you and look forward to seeing you there. And thank you for tonight. Take care.